Well, that was an amazing lunch. Yeah. Maybe someday we could advertise 100 billion sold with some green arches. Yeah, what, 100 billion sold. Blood vessel-less burgers. It was a good. It was a good lunch, to say the least. All right, as I mentioned, I not only am a person, I'm a medical doctor, I'm a grandfather. I teach about good nutrition. Oftentimes in my past, people have said, you know, McDougall, if you just stick to the diet part, we'd like you a lot better. Why do you have to go pick on heart surgery or get a law passed that informs women about breast cancer surgery and that mastectomies are mutilating? Why do you have to do that? Just mind your own business. Just eat your oatmeal. You know, why do you have to go to the state legislators of California and help get a law passed with some of my friends? A couple of them were here, Wayne Dysinger, Don Forster. Why do you, McDougall, have to go get a law passed that forces doctors to learn about what people eat? You know, just mind your own business. Well, ladies and gentlemen, this is my business. I am a doctor. You know, my oath just didn't extend to teaching how to eat well. It also extends to you personally, to protecting you. It's my duty to protect you from those who do wrong. And if I see it wrong, I have to tell it like it is. Unfortunately, I've gotten away with it for all these years. I want to talk to you about, I spoke to you about the heart surgery businesses, the cancer businesses. It's all in the newsletters. You can read about it, or you can watch it online, and it's all there, and all the evidence is there. What I thought would be most appropriate is to deal with the latest scams in the diabetes industry. The diabetes industry. Now, this applies to all of you, because all of you either know somebody or have in the past known somebody who has diabetes, or you've had diabetes yourself. Unless I say otherwise, I'm referring to type 2 diabetes, formerly referred to as adult type diabetes. But now that children are sick with type 2 diabetes, we can't call type 1 diabetes childhood because, yeah, the kids are so fat and sick. This is the cash cow. Diabetes is the cash cow for the medical businesses, the drug industry, the doctor industry, the hospital industry, because diabetics generate so much income for big farm, big medicine, big hospital. You got to figure, yesterday I'll give you another one, the figure I have is $13,700 per year per patient. That's 2.3 times as much money as generated by the average person. There has been some question that has come up, which I'd like to clear up, and that is about type 1 and type 2 diabetes. Completely different diseases. They just share in common, well, they share a few things, but one thing they share in common is both have elevated blood sugars. The other thing in common is they both suffer from severe side effects, such as blindness and kidney disease and so on. But they're completely different diseases. And they must be thought of as different diseases, or you don't know how to care for yourself, and your doctor has no idea how to treat you. First of all, type 1 diabetes has been treated by a medical miracle that was discovered and implemented in the 1920s, called insulin. It is a life and death discovery. Prior to that, type 1 diabetics would be sent to a diabetic ward where they'd die, off to die. But insulin was discovered, and it's a long history which you can learn about. If you go to my January 2017 newsletter, you can click the link. It'll take you through a very exciting history about how insulin was discovered and then implemented in human beings. Well, type 1 diabetes is characterized by the complete lack of production, or almost complete, lack of production of insulin, this essential hormone, insulin, by the pancreas. Pancreas doesn't produce it. Insulin is the hormone that allows for the distribution of the key nutrients that we eat. Insulin opens up the cells so that sugar can get into the cells so that your regular cells can have energy, metabolism. Insulin opens up the fat cells and allows fat to be stored for the day when no food is available, which hasn't come. Insulin's involved in protein metabolism. That's what insulin does. Without it, you die. A type 1 diabetic does not produce sufficient insulin. They will die of something called ketoacidosis quickly. Type 1 diabetes. Now, type 2 diabetes is a completely different disease. The pancreas is efficiently and busily making insulin. It will make as much insulin as somebody without diabetes and often twice as much insulin as somebody without diabetes. It's just that the insulin doesn't work at the peripheral tissue level. The insulin doesn't do its job. It doesn't allow sugar to get into the regular cells. It doesn't allow fat to get into the fat cells because of something called insulin resistance, which is brought up here, which I'll explain to you in maybe a little more practical terms. So we have on one hand, we have complete lack of insulin production, type 1. And we have on the other hand, not just sufficient, but over-sufficient production of insulin, type 2. And then we have a spectrum in between, type 1 and type 2 diabetes. And I call this, and so do my colleagues, type 1.5 diabetes. Type 1.5. And I should be able to answer the questions you gave to me yesterday in the next couple of minutes. Type 1.5 diabetics. They produce enough insulin to stay out of the hospital and to keep from dying of ketoacidosis. But they don't produce enough insulin to cover all the body's needs. Now, how in the world do you tell if somebody has type 2, type 1, or type 1.5 just by looking at them? You can't. But you can guess, or I can guess. Dr. Lim can guess. My son, Dr. Craig McDougall, can guess. Dr. Mika McDougall and many other people who understand this concept, they can guess and they must guess. When people come to my 10-day live-in program, Dr. Lim or myself have to make a judgment day 1 in the evening, as soon as they arrive. We have to make judgments about their medication. And here's how it goes in terms of our thinking of the patient. And some of you have been there, so you know the conversation. I ask people who have diabetes to personally talk to us. So the person who is attending the program comes up and describes a list of medications they're on. I take a look at them, I take a look at their medications, and then I must guess. Are you a type 1 diabetic? Are you a type 2 diabetic? Are you a type 1.5 diabetic? Because I have to make decisions that evening. Otherwise, if you are taking insulin and the diet works as I say it will, you have a good chance of running hypoglycemia, in other words, too low of blood sugar, and being at breakfast the next morning, standing up and falling over into your oatmeal because your sugar is too low because you're still taking the insulin. I can't let that happen. It has happened. I mean, there have been times when I said, look, you should stop the insulin, and they didn't. And they were up at 3 in the morning with a blood sugar of 20 or 30, on occasion calling the ambulance. So a decision has to make. Now, how do I make this guess? Well, I look at you and I go, well, let's see. I got your list of medications. You told me your blood sugars are such and such, say, and I'll be talking in US units. If you want to divide it into international units, you use the division factor of 18. So the person says to me, well, I usually run blood sugars of 130, 170, 250, et cetera, and I'm taking insulin and sulfonylureas and metformin, et cetera, and I have to think, now let's see. How am I going to serve that person best? What do I guess? Are they type 1? In other words, absolutely require that insulin and medication. Well, they never require the medication. By the way, I always stop all the oral pills the first night, no exception. So all the pills are stopped. But the question is, do I continue some insulin or not? They could be type 1. I not run the risk. It takes a couple of days to run into ketoacidosis, so it's not going to happen overnight. Can't leave them on too much insulin. I say they'll get hypoglycemia, so I must guess. And say you're overweight. My guess is I say, you know, I believe you're type 2, in other words, non-insulin dependent. You got those words. You got to clearly understand non-insulin dependent. Type 2 or type 1.5, non-insulin dependent. In other words, you don't have to have insulin. Do I guess that you're non-insulin dependent and that I should reduce or stop your insulin? Remember, I always stop the pills. So I will generally err, and I teach my students to err on the side of too little medication rather than too much. Well, what's going to happen? They're going to run a blood sugar of 350, 450. Who cares? Who notices? But you don't want them running a blood sugar of 30 to 40. That's a big deal. So I guess less rather than more. And say the person's taking, I've had people come in taking 140 units of insulin. Not unusual. I might say, stop all your insulin. They go, oh, what kind of a crazy man am I talking to? Yes, stop all your insulin. And most of the time they do because they know about the program, what they want, and what they want to accomplish. And they do. Or I may say, look, cut your insulin in half, or cut it by 70%. It's always cut the insulin, even if they're type 1 diabetic. So I make this guess. If you're overweight, I guess type 1.5, type 2. If say you come really thin, and you have a real strong history that this is type 1 diabetes, which, by the way, the destruction of the pancreas is most commonly caused by an autoimmune reaction that occurs as a consequence of dairy protein. It's called molecular mimicry. You eat this foreign protein, cow protein. The body makes antibodies to the cow protein, which then attack the beta cells of the pancreas and kill the pancreas. That's how you get type 1. So anyway, here the person comes in. They're, say, let's just make a guess. Say they're 35 years old. They've had diabetes since they've been 11. They're taking 40 units of insulin, usually more. By the way, the body requires 40 units of insulin. Keep that in mind. That's what the body produces on average, 40 units of insulin. So they've been on insulin, multiple shots, insulin pumps, et cetera. And I go, oh my goodness, this is clearly a person with type 1 diabetes. They don't make enough insulin. So what I say to them is, I believe you're type 1 diabetic, you're trim, that's my assessment, I think your pancreas is destroyed. However, the food makes the insulin work so efficiently that you must reduce the dose. And so I ask them to reduce the dose by about 30%, whether it be an insulin pump, multiple shots, long-age insulin, whatever, about a 30% reduction in insulin. And I guess usually really good. I've been doing this for 40 years. I also tell them to take either chocolate pudding or brownies back. You guys didn't have the brownies this weekend. You had the chocolate pudding. But I tell them to take it back to their room, and if you develop hypoglycemia, excuse me, you treat it just like you always treat hypoglycemia, with candy, sugar, etc. We don't want you to have a low sugar reaction. Okay, so let's get back. We've got the type 2 diabetic, which makes tons of insulin, just doesn't work, and I'll tell you why in a minute. We got the type 1 diabetic who doesn't make any insulin. Then we have something in between called type 1.5. How can you figure that out? Well, there are multiple ways, but time is the best way to figure it out in my experience. What I do is I minimize the medication. If they're type 1.5 and I guess right, that means no medication. And what we do is we check their blood sugars fasting every morning, and their blood sugar may stay the same, say 180, 280, may go up 180 to 280, whatever. So they're still fat. They're still overweight. They ask me, well, will they ever become normal? Will I ever be able to go without any insulin and run a normal blood sugar? And the answer is, I don't know. I don't know. We have to see in time. When you drop from 300 pounds to 150 pounds, then we'll know. Because at 150 pounds, if your blood sugar is still elevated, in other words, you've gotten rid of all the fat that causes insulin resistance, then we'll know you're type 1.5 diabetic. Now, I do treat people with this intermediate, this spectrum. I do treat them under 3 circumstances. Very important. I never treat type 2 diabetics with medication. Why? Because they make lots of insulin. They don't need medication. I always treat type 1 with medication, insulin. But who do I treat who has the spectrum, the 1.5? There are 3 circumstances under which I give medication. The only medication I give is insulin. I will not give any of the pills. Never. The medication I use is insulin. I generally give it as a long-acting insulin called Lantus. There are other varieties, but Lantus is what I like, what I'm familiar with. There are other similar long-acting choices, but that's my experience, Lantus. It works over a 24-hour period of time. A type 1 diabetic can use Lantus only. Rarely do they, but they can. It's what it's made for. What I do is if you're a type 1.5 diabetic, I tell you, if you lose too much weight, then you need to be on some insulin. I'm fewer than 150 pounds. What if I weighed 120? Yeah, and I had insulin insufficiency. You'd say, look, McDougall, you're thin enough. We got to stop that weight loss. And if you knew me well, you were my doctor, you'd say, well, obviously you keep getting thinner because you don't make enough insulin. Your cells are starving. You don't make enough. You make enough to stay out of the hospital, but not enough to stop that weight loss, not enough so the fat cells open up and allow fat in. So I will give the patient a little insulin. How much? Well, in general, I guess 10, 20 units at night, 1 shot of insulin. And the weight loss stops, or they gain the lost weight that they shouldn't have lost. So excessive weight loss is a reason that I treat people with type 1.5 diabetes. If they develop symptoms of diabetes, such as excessive thirst or urination, then I'll give them a little insulin to correct those symptoms. And the third reason, I'm a well-rounded doctor. I'm a general doctor. I have to think of everything, including your psychological comfort. So if you worry about the numbers, your mother-in-law worries about the numbers, your doctor worries about the numbers, your attorney worries about the numbers, I'll give you a little insulin. So you stop worrying about the numbers. I don't lose any sleep, but I know you will because the numbers are high. That's just the way it is. I'm not making light of this. I'm being very serious with you about what goes through my thinking. So if you're a type 1.5 diabetic, I will give you a little insulin to stop the weight loss or cause weight gain that's necessary. If you have symptoms of diabetes such as excessive urination or excessive thirst, I will give you a little bit of Lantus. And if you worry about the numbers, then everybody will be happy if you just shoot yourself once a day, right? I'll do that too. Are you all, well, I'll ask you later, but keep in mind if you're not clear, the question came up last night, how do you decide to treat somebody with diabetes? It should all be crystal clear for you now. If it's not, maybe I'll have a minute to clear it up again. However, you can find all of this where? In my January 2017 newsletter. Everything that I'm going to talk to you about is all documented there. So let's go on to type 2 diabetes. What causes type 2 diabetes? Yeah, getting fat. It's plain and simple. It's from getting fat. That's type 2 diabetes. The fatter you are, the more likely you are to have type 2 diabetes. And why is that? Well, it's because it's the way it's supposed to be. It's the way the body works. It's called survival. The human body is designed to survive. So how does the human body act in terms of survival? Well, it was a good summer. We had lots of corn and potatoes and so on, and fall is pretty good. But winter's coming along, the body says, and during the winter there's likely to be less food, so we better put on a little fat so that you can make it through the winter. So the body puts on 30 pounds of fat to get through the winter, 60 pounds, whatever it has to get through the winter. That's good. That's good. The body says, oh, you made good decisions, body, to put on some extra fat, which is the metabolic dollar, which we store for times of starvation. That's good. And then what happens is the body hits, say, 60 pounds. And then it says, you know, this is not in my best interest. If I get fatter, I won't be able to climb the tree and get away from the saber-tooth tiger. I won't be able to get into the cave hole entrance, and I will freeze to death. And so what the body does is it develops insulin resistance. The insulin doesn't work well. Remember, insulin puts fat into fat cells. The body says, you're fat enough. So the insulin stops working by a variety of mechanisms that have been discussed and could be discussed further, but not necessary. It just is a normal adaptation. It is not a disease. So the insulin starts working efficiently. You don't gain much more or any more fat, but the blood sugar goes up because the insulin isn't working efficiently, so the sugar can't get in the cells as well, and you have type 2 diabetes. Now, why else do I know this? Because I've been in this business I've been in this business half a century, but I've been in the business of taking care of people with good diet for 40 years. But I'll put this on a half a century of work. What I have observed in a dozen cases or more is I've observed people who are massively obese. You know, they're not 250 pounds, 300 pounds. They're 500 pounds or 700 pounds. Or you hear on the news about somebody who's laying in bed. They have to go to the hospital. They have to bring a forklift in to lift them up and take them to the hospital because they weigh over 1,000 pounds. How did that happen? And, before I tell you how it happened, let me tell you the other thing that surprises the patient, friends, and doctors, is this person may be massively obese, but they don't have diabetes. Their blood sugar is normal, their cholesterol is normal, their joints are ruined because of the weight. They have no high cholesterol, they're on no blood pressure pills, no diabetic pills. Everything is fine except they're massively obese. Now, how did that happen? I'll give you a second to think about it. How did that happen? They were not able to develop insulin resistance. That's how it happened. These maybe 1 in 500 people. They don't develop insulin resistance like the normal person does, where the body says, that's enough, 60 pounds is enough, forget it. And then with the elevated insulin, other things happen and so on. But this person, they never develop insulin resistance, and they just keep gaining and gaining and gaining. But they're otherwise not ill. And you go, oh, hey, George, how come you haven't had a heart attack? How come when they studied your arteries, they're perfectly clear? How come? Well, it all makes sense to me, but it confuses everybody else. How do you cure type 2 diabetes? Remember, type 2 diabetics make as much insulin as everybody else, yes? They make loads of insulin, twice as much sometimes as everybody else. So how do you cure them? The insulin doesn't work because they're too fat, right? The body's trying to adapt to survive. So the body develops insulin resistance. The insulin resistance is not required if you aren't too fat. So how do you cure type 2 diabetes? Well, one of the most popular methods these days reported to patients, doctors, in medical journals is to cause surgical malabsorption, to go in and rearrange the person's intestines, called bariatric surgery, to make the person lose weight. Look at the cure rates for a minute. This is the cure rate. It's 80% cure rate for just doing surgery and cause them to lose weight. Isn't that phenomenal? What a modern medical breakthrough. Just cause people to develop intestinal malabsorption. And I'm not joking. This is big business. So we've got a way for bariatric surgeons to buy mega houses and Teslas and just be as wealthy as can be because of this. But I'm a doctor. I have to think about my colleagues and other professionals. I don't want them to starve. So there are other means to cure type 2 diabetes. Dentists can cure type 2 diabetes. All they have to do is wire your teeth together. Yeah. Cancer chemotherapists can cure type 2 diabetes. They just need to make you sick enough with the drug so you lose weight. Neurosurgeons can cure type 2 diabetes. They can just do a prefrontal lobotomy and take away your appetite, and they've cured type 2 diabetes. Well, I don't want to leave out many of my colleagues. So the future I see for general surgeons is to cure type 2 diabetes. And the way you do it is you do bilateral lower extremity amputations so the patient can't get to the refrigerator. and you cure type 2 diabetes. It's virtually 100% curable if it's type 2. By definition, it's 100% curable. And you say, well, what about, well, it's called type 1.5 diabetes. But type 2 diabetes is 100% curable by definition. Treating diabetes. Let's talk about the standard medical treatment of diabetes. To get approved by the FDA for a medication to treat diabetes, beyond obviously killing the patient, you can't do that. Not right in front of the FDA. But all you have to do, and this was addressed in 2008, and is still being addressed and has never become an official requirement, it has just been a recommendation. All you have to do is show that your drug can lower blood sugar. You don't have to prove it doesn't kill your patients. Proposed in 2008 that that be a requirement, but it still isn't. It's just a recommendation. The recommendation is, in addition to lowering blood sugar, you ought to show that the patient lives longer and healthier. Just a recommendation. However, in 1987, I love this statement by Hockaday. He said, it's important to remember that diabetic control means a lot more than blood sugar control. Excuse me, ladies and gentlemen, 99% of your physicians, 99% of your pharmacists believe that the efficiency, the standard for being a good medication is its ability to lower blood sugar, period. All right, we talked about a second-line medication yesterday called sulfonylureas. That's about 30% of the sales. This kind of medication became, well, it actually was developed a long time ago. It was used as an herbicide. But since I was a young doctor, I started in 1968. Prior to that, they'd been using sulfonylureas to treat type 2 diabetes. Since 1972, in the physician's desk reference, there has been a warning on every diabetic pill, including, up until recently, the drug companies are winning a little bit, including especially sulfonylureas, about sulfonylureas, warning on an increased risk of cardiovascular mortality. That means strokes and heart attacks. And in the UGDP study, they showed, comparing sulfonylureas to placebo, that the risk of dying of heart disease was increased by 2.5 times. That's a second-line drug. Then we have this drug, Avandia, approved in 1999, very popular drug. And it was just going gangbusters for stockholders and everybody, because it was not a sulfonylurea and didn't have that reputation like sulfonylureas have had since the 1960s. So this was new. What could it do? It could lower blood sugar. So it was approved and didn't obviously kill people after the first few doses. So it was approved. But it was studied, and Neeson reported the results in 2007 in the New England Journal of Medicine. Well, it lowered blood sugar based on hemoglobin A1C, which we're going to talk about. But it increased heart attacks by 66%, 39% more strokes, 20% more deaths from cardiovascular-related problems, and 100,000 heart-related problems for seniors. Bad day for GlaxoSmithKline. They have since paid a fine to the FDA of $3 billion for their mischievous behavior. And currently, there are 50,000 lawsuits going on against the manufacturer of this drug. It's banned in New Zealand. It was almost taken off the market in the US in 2007. In Europe, they warned in 2010 not to take this drug. But it doesn't matter, because when you design a drug, when you get it ready for market, in your profit and loss statement, you figure in the lawsuits and the fines. It's just business. Don't take it personal. It's not a conspiracy. So this is a very successful drug. But the patients that I see at the clinic who are type 2 diabetic, at least half are on this medication. Here's the warning that's carried in the current physician's desk reference. The current warning is, this is black box warning. These are heavy black print. The warning is congestive heart failure and heart attacks. Well, how does your doctor do this? How does your physician, he or she, or your dietitian, or your physician assistant, or whatever, how do they look at you and say, you need to be on these medications? And regardless of the fact that it's 100% curable with weight loss of any kind, type 2 diabetes. And most permanently and healthfully, it is cured with a starch-based diet. But I admit there's virtually no education in nursing school, dietetic school, medical school about diet. It's just not part of the agenda. What do medical schools, well, I help educate medical students. And so we get medical students from all over the world. And they're, of course, astonished by this. Most of them came knowing this. And they're not surprised when we discuss this because a medical school's job is to get the students ready to pass the boards. That's their primary goal, is to get their students to pass the boards. And their secondary goal is to train physicians in a trade. This is trade school. You learn how to do things. Now, excuse me, let me go back. I'm not trying to say that there is nothing good about medicine, that everything's wrong, all doctors are wrong thinking, or they're evil. I'm not trying to say that. I'm just trying to get down to the business facts. This is just the economics of it. Don't take it personal. Well, here's the first line medication. It's called metformin. When I was a student, it was called fenformin, but it was taken off the market. They changed it a little bit. They changed the metabolic structure. It was taken off the market when I was a student because it did cause a lot of lactic acidosis and death. So that was banished from the drugs, and a replacement was a slightly structurally modified chemical called metformin. It's the drug of choice. Of 58 million Medicare claims, more than half of them are for metformin. Doctors believe in this. Patients believe in this. And you heard some more positive information than I will give you yesterday from Dr. Rudolph. He's such a nice guy. I think you ought to look at PLOS Medicine, independent journal, just like the NIH or any NIH speakers come completely independent. So does research published in this open access journal from the Public Library of Science Medicine. And they reviewed, and by the way, you have this free instantly. You can get it right now if you want it. It's free. Where do you start? My January 2017 newsletter. And so they looked at all the various studies on metformin. Oh, let me just take you one step back. The idea that metformin reduces the risk of dying of heart disease comes from the United Kingdom Prospective Diabetic Study that was published about 1990, which was on a group of 342 people. That's it. Small subgroup, 342 people, 3 decades ago. That's where the claim lies. Well, anyway, so PLOS Medicine, they reviewed metformin to see whether it helps in terms of cardiovascular strokes and heart attacks. I don't mean to confuse you, but I must read their conclusion, and then I'll tell you what it means to me. Although metformin is considered the gold standard, it's treatment of choice, it's first-line therapy. Its benefit-risk ratio remains uncertain. We cannot exclude a 25% reduction or a 31% increase in all-cause mortality. We cannot exclude a 33% reduction or a 64% increase in cardiovascular mortality. I think it's all absolutely perfectly clear to everybody who is listening. Do I stop metformin on every patient I see that comes to me and I become their doctor? Do I? Yes, thank you. A whole bunch of drugs. We got all kinds of drugs out there now. I can't keep up with them. Patient comes in, they say they're blah, blah, blah. Like, oh my goodness, let me look it up. Or one of the medical students says, well, we just learned about this, so we can tell you what it is, doc. Or Anthony Lim, he's much fresher and keener and younger than I am. He'll say, oh yeah, that's one of the new whatevers. So there are a whole bunch of new whatevers out there, and you can find out what they are and how they work and what is special, especially deadly for them, where their warnings are. Dr. Rudolph talked a little bit about it yesterday. I won't bore you with the details, but if you want to go know the details, you want to get started, January 2017 McDougall's newsletter. So how do we assess the benefits of treatment? Remember, the only requirement to be approved by the FDA is it must lower blood sugar. Now, seriously, I mean, they want the drugs to help patients. It's not like, you know, just lower blood sugar, make money, and we'll let you get away with it, and you won't go to jail. They really want the right thing to be done, but they do not require it. You just have to lower blood sugar. And so the way you test blood sugar is in two methods. One, you can do a momentary assessment by sticking your finger and checking your blood sugar. And remember, the conversion factor is 18 if you're doing international units. And a normal blood sugar is 100 milligrams per deciliter, fasting. It goes up after you eat, it's supposed to. Well, that's a momentary instantaneous measurement. There's a new measurement that was discovered many years ago. Like as one of my participants says, it was many years ago when I used to walk to school with a backpack in the snow, uphill, both there and back. That's when it was discovered, or that's when hemoglobin A1C became popular. So hemoglobin A1C is a long-term measurement. How long-term? It was mentioned 3 months. Well, the reason it's 3 months is because blood cells die in 4 months. Yeah, so it's a measurement of 2 to 3 months, certainly not after 4 months because the blood cells are dead. So you're looking at 2 to 3 months of blood sugar control, and I published this in probably the second national best-selling book I published. Here's the figure that I put in the book, which is called McDougall's Medicine, A Challenging Second Opinion. I wrote that in 1985. So 95 to that was 30 years ago. You know, my son, Dr. Lim, some of you read this book and you go, how in the world did he know all this more than 30 years ago? It was because it was all published. It's not like God talked to me. It was all in the literature. It's all there. It's still there. It's there for everybody and anybody to read. So what we're looking at is we're looking at a hemoglobin molecule on your left with not too many sugars attached to it. Glycosylated hemoglobin. Glucose added to the hemoglobin molecule. So when you have high blood sugar, you have more sugars attached to the hemoglobin molecule, which distorts this molecule. And as a result, there are some basic things that I could talk to you about and have talked to you about before. This just doesn't happen to hemoglobin. It happens to brain cell proteins and liver proteins and all the proteins of the body. They are distorted. Not good. Not good. But that's what they mean by glycosylated hemoglobin or hemoglobin A1C, is how much of that hemoglobin has extra sugar attached to it. Normally about 6% of the hemoglobin has sugar attached to it. But a person with diabetes, then there's more glycosylated hemoglobin, and it might go up to 8%, normal being 6%, international or US standards. I've seen hemoglobin A1Cs of 14%. Will you please remember these numbers? A normal hemoglobin A1C like I have, or you have if you're not diabetic, is 6% or less. And people with diabetes have hemoglobins elevated. Oh, I do need to get into this, elevated. Well, let's say it's 6.2%. Well, there are doctors out there that will treat you just to nip it in time. Or maybe if it's just 6%, it could be pre-diabetes. So we should put you on medication just to catch it in time. That's the standard practice. But anyway, normal without medication is 6% or less, and your doctor will go ballistic most of the time if it's above 6%. All right. So in general, diabetics have a hemoglobin percent of 8%. All right. There are 7 major studies only that have looked at the outcome, the most important outcome. Sure, you can lower blood sugar and hemoglobin A1C, but there are 7 studies that have looked at what you really care about. Now, you don't care whether you die at 90 with a blood sugar of 300. You don't want to die at 30 with a blood sugar of 100. You don't care what your blood sugar is, you just want good health, and Dr. Rudolph mentioned that. So there have been 7 studies that have looked at the difference between aggressive treatment and standard treatment. The goal of aggressive treatment is to make the hemoglobin A1C 6%. Let's go through them quickly, and again, you can look at all this. I think every one of them is open access. January 2017 newsletter, just hit the link, it's there. So you have the United Kingdom Prospective Diabetes Studies, which is the bragging rights for most prescribers and the drug companies. This was done about 3 decades ago. And what the result was is that the hemoglobin A1C in not aggressively treated patients was 7.9% at 10 years of therapy, whereas aggressive treatment was 7%. Now, the absolute reductions, Dr. Rudolph gave you, I mean, he gave me such a great foundation to have this discussion with you. The absolute reductions are the following. This is the best. Any diabetes-related endpoint, 5 fewer in 1,000 patients. Diabetes-related death, less than 1 in 1,000. All-cause mortality, 1 in 1,000 by aggressive treatment. Heart attacks, 3 less in 1,000, but more weight gain and more hypoglycemia. Hypoglycemia, ladies and gentlemen, is very, very real and dangerous. If you are aggressively treated, you're likely to be picked up for a DUI and go to jail until they figure out you're not drunk, you're just being aggressively treated. You're likely to, and everybody who's a serious diabetic who is on insulin or insulin-producing medications, almost everybody knows about hypoglycemia and how dangerous it is. Well, anyway, there's the best. That's the best. That's the most promoting. The research used, the justification given is this 1 of 7 studies that shows these benefits. Let's see. They had the DCCT study, which was done on type 1 diabetics aggressive. These are type 1, so I have to divert a little bit. Type 1 diabetics, what they found is that at the end of the study, there may be an increased risk of coronary artery disease in people aggressively treated. Yeah, there's more weight gain, higher blood pressure, higher levels of triglycerides, higher total cholesterol, higher bad cholesterol, et cetera. That was the DCC trial. Let's see, we had the veterans, the first veterans study that found a strong tendency toward worsening cardiovascular outcomes in patients with intensive control. Yeah, and then we had the TRACE study, the biggest study done, at least at one point in Europe. The TRACE study, and what they found is diabetic patients treated with oral hypoglycemic agents or insulin, these are type 2 now, but not those treated with diet alone, have a significantly increased mortality. Following acute myocardial infarction compared to non-diabetic patients. Well, and then they got serious. The drug companies are really fighting back. And they did the ACCORD study. We were on a trip, many of you, some of you were maybe with us, it was in February of some year in Costa Rica, and this study came out, or the newspaper headlines came out about the ACCORD study, and what they were was the National Heart, Lung, and Blood Institute stopped the ACCORD study 17 months early because it was, well, they didn't use the words killing people, or they may have, but that's why they stopped the study, because those aggressively treated were dying of heart disease, more than those not aggressively treated. That's a bad day for the drug companies. So that's the Accord, and this was published in 2008. I'm going to show you the last 3 studies published. They were published in 2008 in the New England Journal of Medicine. So you have the Accord, then you have the Advance. There were no significant effects on the effects of the type of glucose control on major cardiovascular events, death from cardiovascular causes or death from any cause. They just didn't show any increase, but they showed no benefit. And people got fatter and they had more hypoglycemia. Yes, they did. And then there was the last veteran study, which again was published in 2009. Intensive glucose control, no significant effect on rates of major cardiovascular events, death, or microvascular disease. Now, I must introduce that concept to you. Macrovascular disease is the big blood vessels, like in the heart that they see on angiograms, or in the brain, the big blood vessels, macrovascular. Then there are microvascular diseases, like the little tiny blood vessels in the eye or the nerves of the kidneys. So they showed no microvascular benefits except for maybe less protein in the urine. These are all 7 studies. There are no others. I'm not hiding anything from you. So drug management is to, in most doctors' minds, there are exceptions. Please, all of you who are exceptions, do not take offense, just stand up and fight for the patient. So drug management is to lower the blood sugar, even if it causes more death, more heart disease, more sudden death, more weight gain, and more low sugar disasters. Microvascular disease. This is the sales pitch for the drug industry and doctors who still believe. This is faith-based medicine. You must believe. So doctors who still believe, and they understand that we don't reduce the risk of dying of macrovascular disease, the heart attack and strokes, the pitch is, well, yeah, but you reduce the risk of microvascular disease like blindness or kidney failure or nerve damage. That's the pitch. Does it really? I did a review of this, published it in my 2011 McDougall newsletter, and I looked at all the studies done, and they're all here. And they're not equally divided, ladies and gentlemen. The bulk of the evidence says there's no benefit. And does my review impress you? Maybe. But the Accord, the researchers involved with the Accord study, they published in The Lancet in 2010 the same summary, and that is, the effect of intensive treatment on hyperglycemia on microvascular outcomes in type 2 diabetes. The analysis, intensive treatment did not reduce the risk of microvascular disease, as they said. And microvascular benefits of intensive therapy should be weighed against the increase in total and cardiovascular disease-related mortality, increased weight gain, and high risk for severe hypoglycemia. Your doctors all know this. All right, so the BMJ came out, British Medical Journal. I'm talking about the best publications in the world. Not that they're not tainted, they are, by some contaminated thinkers and drug money. They are affected, but let's just say they're some of my favorite journals. Lancet, British Medical Journal. The effect of intensive glucose-lowering treatment on all-cause mortality, cardiovascular disease, death, and microvascular events in type 2 diabetes, analysis, meta-analysis. Harm associated with severe hypoglycemia might counterbalance the potential benefit of intensive glucose-lowering treatment. Intensive treatment was associated with a significant reduction in only one endpoint, and that was the rate of protein in urine. I know I'm beating this to death, but I must. So let's go back to metformin. And this is what 98% of your physicians and your professors, those of you who are residents and students, will tell you is that when we prescribe metformin, not necessarily because of its cardiovascular benefits, which are in question, as you can read in PLOS Medicine, published in 2012, they say, well, it's proven that metformin reduces the risk of tiny blood vessel changes. It's proven it's proven in the United Kingdom study that I talked to you about, and it was based on a small subset based upon whether or not they required retinal photocoagulation. That means taking a laser beam, whether or not the patient had to have the back of the eye treated with this laser. This is an extremely subjective endpoint. But that's it. All right, this was covered yesterday, thank goodness. Dr. Rudolph did this. There are all kinds of new drugs. Since 2008, the drug company said, well, we're big boys and girls. We'll step up to the plate, and we won't just look at lowering blood sugar. We'll make sure the patients live longer as would be morally justified. That's what they think. I'm sure that's what they're thinking. But they didn't say. So they came out with all kinds of new drugs. And there have been 17 studies started. 3 have been published in the New England Journal of Medicine, and those were discussed last night, so I won't go over too much except for what you should have noticed last night from Dr. Rudolph, and which I will emphasize again, is that the cardiovascular death benefits are much fewer than 3%. Much fewer than 3%. Here's one of the results. This is 7,000 people. These studies are all paid for by the drug companies, by the way. 7,020 people, no significant difference in rates of myocardial infarction or stroke. Oh, you can read it. Increased risk of genital urinary infections, leg amputations, foot amputations. Fewer than 3%. 7,000 people, tens of millions of dollars. And your doctor and your pharmacist, usually they stand up with a big smile and they think, wow, I'm just doing you so much good. Victoza. Who's the lady, the food chef that recommends that? Dean. Paula Dean, thank you very much. She's been a drug spokesman for this, and boy, we know Paula knows how to eat. Then another study, this really hasn't hit the market except in combination with insulin. Again, fewer than, we're talking about 3,000 people, far fewer than 3% benefit. That's the best they can show with the most money they can gather. And, all right. Now, one other thing, and I do have enough time to cover this, that's about Star Wars medicine. Boy, do I have trouble with this. Not me, but I have trouble with my patients with this because they want an artificial pancreas. That's what they want. They want a pancreas transplant. We've been talking about that for 50 years. Don't hold your breath. So we have close to a pancreas transplant. Not really, but that's what people think, and maybe even the physicians think this. It's meters and pumps that they attach themselves to. So these meters that they attach to their skin, continuous blood glucose monitoring meters, they will check the blood sugar every 5 minutes. Boom, boom, boom. And so the patient is constantly aware of what their blood sugar is. And as a result, they can self-medicate. They can give an extra shot here, an extra shot there, right after lunch, right before dinner, etc. Or and that costs $1,000 to $1,400 just for the meter. And then you have the sensors, which you have to change every 3 to 7 days, which are $35 to $100 a piece, the sensors are. And when you wear this monitor, every day you must check your blood sugar independently 2 to 4 times a day with a finger stick to make sure your continuous monitor is working. And then you might invest in a pump so you don't have to shoot yourself with extra insulin all the time, and that's $5,000. There has never been shown any health benefits ever for this approach. So a study published, what was this, like a couple weeks ago in JAMA, Journal of the American Medical Association, 2017, probably January, I would guess. What they did is they looked at the standard in blood sugar control, which is hemoglobin A1C. Yeah, remember, that's what you need to be able to do to get in the marketplace. You need to be able to lower hemoglobin A1C. What they did is they compared finger sticks with the efficiency of these monitors. And what they found is they found a 0.4% benefit. All right. I must pause for a second and give you the real life situation on this, because I deal with these patients all the time. Let's just make up a story. Let's make up a story about a man and his wife. They come in, they've had a great marriage. They've had 35 great years, and she's been diabetic for a while, maybe progressively, started out with sulfonylureas and then added other pills, and then the doctor says, well, you're just not controlling your sugar, so you must take insulin shots, and that's bad. But then she's told she must do continuous glucose monitoring with one of these meters and wear a pump. What happened to that family? They went from talking about the grandkids and where they're going on vacation to, what's your blood sugar now, honey? How much insulin are you going to give yourself now, honey? Excuse me, this could happen every 5 minutes. What happened to life? What happened to the quality of life in these people? It has been destroyed. So one of the first things I do, and I don't always get away with it, but a patient shows up on Friday evening, and what I say is throw away the pump. They think I'm a devil. Why would I ever do that? Because I want you to have your wife back. I want you to have your children back, your grandchildren back. I want you to have your life back. And this pump is destroying your life. Yes, it is. January 2017, McDougall newsletter. All right, so I've told you how you get type 2 diabetes. You get fat. So you go to the doctor, and the doctor says, George, Helen, you're too fat. And I just got your blood sugar results back, and your blood sugar is high, so you got diabetes. And so I want you to do this. I want you to lose weight, and your diabetes will go away. Type 2 diabetes will go away. Just lose weight. And here is instructions how to do it. This is a diet sheet that I got from Eli Drug Company. You go home, follow this, and lose weight, and your diabetes will go away. So George and Helen go home, or Helen. They're not together. George or Helen go home. They try and lose weight. But before they leave the office, the doctor prescribes insulin or medications, and most of them do, not all of them, which increase the insulin in the body, and insulin causes weight gain. Everybody knows that, and this is not up for discussion. The average weight gain in the studies I showed you, compare standard treatment to aggressive treatment. Standard treatment, the weight gain may be 9 pounds. The aggressive treatment is 18 to 20. So Helen and George go home, different patients, same day. Take the medication, the insulin or the sulfonylureas, and they try and lose weight. And they come back to the doctor's office. The doctor says, get up on the scale. I told you to lose weight. Look at that, you're fatter now. And I just checked your sugar, and it's higher now. I must give you more medication now. And you get into this vicious cycle of taking medication that makes you fatter, which makes you more diabetic, which never ends until you stop the medication. That's why I stop your medication the first night if you're a non-insulin dependent diabetic. Clear enough. Okay. How long ago does this knowledge go back? Shirley Sweeney published studies on his healthy medical students. By the way, this is as true today as it was back in the 1920s when this was done. The truth does not change. So he took Shirley, Shirley is a boy, man. Shirley Sweeney took his medical students, he fed them various kinds of diets, and then did the standard for diabetes, which is a glucose tolerance test. And what you see along the bottom line, which is the x-axis, is the time. And along the y-axis, which is the one that is rising, you see the blood sugar levels, and then you see the blood sugar levels plotted over the next couple hours. When he fed them sugar, and what I'm talking about is sugar and candy, pastry, white flour, baked potatoes, syrup, bananas, they all tested non-diabetic. And fed them protein, lean meat, white eggs, and so on. And their blood sugars rose into a pre-diabetic at least state. These are healthy, young, 20-year-old medical students. And then he fed them fat. And all of them became diabetic. They all became diabetic. Yeah. Sir Harold Percival Hemsworth. He should have stopped all this nonsense. He's really the father of diabetes, in my opinion. He published studies in the British Medical Journal in 1940, which should have stopped all arguments, should have stopped all the drug companies, should have stopped all the argument about diet, all of it. And what he did is he took patients with type 2 diabetes, he fed them a high carbohydrate diet, which is what I recommend. And you see the bottom line, the lower line, their blood sugars improved, were good. And then he fed them a low carb, high fat diet, and their blood sugars became worse. Hemsworth knew this. All honest doctors know this, unless they're on red and they're busy looking at the nice-looking person who brought in the donuts and the pizza. And, we won't go there. All right, Brunzell published in 1971 an article in the New England Journal of Medicine. What Brunzell and his group did is they took people with type 2 diabetes and they fed them synthetic diets. One diet made of sugar and maltodextrans was 45% sugar. And then what they did is they fed the same people a diet with almost twice as much sugar. 85% of the calories were from sugar. And every aspect of their diabetes improved. Fasting blood sugars, 24-hour sugars, 24-hour insulins, everything improved. Now, what Brunzell said is that this shows that sugar makes insulin work more efficiently. Remember, sugar causes diabetes. That's what your friends and physicians. Predican, we've mentioned him. He published this in 2005. It's a little hard to see it, and it's not worth going through, but what he showed is the exact same thing I'm telling you that our work shows. Again, there's nothing original. God didn't speak into my eardrum. This is knowledge that goes back for thousands of years. Let's see, James Anderson, University of Kentucky, published this in 1979, multiple studies showing that he got virtually every type 2 diabetic off pills, and 11 of 20 patients discontinued insulin. These are thin people. It's not due to weight loss, it's just the change of the kind of calories. From calories that paralyze insulin, which are called fat calories, to calories that make insulin work more efficiently, which is called sugar calories. Oh yeah, you say, oh, that's outdated old information. Well, Diabetes Care, Neil Bernard published in Diabetes Care his research, you all know Neil Bernard, showing that vegans, which is basically, in fact, I know it was the diet that Mary and I recommend. That's the diet that they used in Bernard's study. They showed that they improved, took less medication compared to people on the American Diabetic Association diet. And then Diabetes Care 2013 looked at, this is 2013, what's that like? Fewer than 3.5 years ago. They took people with type 1 diabetes, taking insulin. They gave them fat. The fat paralyzed the insulin, which required them to take more insulin to get the same blood sugar control. Let's see, we published our results we've published a couple times. We published them in October of 2014 on 1,615 people. We put everybody in the study. Blood sugars did not go up. They did not go down. But, well, let's see. They lost on average in 7 days. No conscious behavioral change. They just ate the food you ate this weekend. The average weight loss was 3.1 pounds. Eating as much as they wanted. The average cholesterol drop was 22 milligrams per deciliter. The international conversion is 38. So they dropped 3/4 of an international unit, or 22 milligrams per deciliter in 1 week. No medication changes. The drop in blood pressure in people with high blood pressure was 18 over 11 millimeters of mercury. But, which you'll find when you read the study, is nearly 90% of people reduced or stopped their diabetic and blood pressure medications, type 2 diabetics. This is a big problem, ladies and gentlemen. We're not talking about a few studies of time in history. We're talking about right now here, planet Earth, everything. This was published in JAMA in 2013. It was about China. Before 1980, they say in this article, before 1980, there were fewer than 1% of the population with diabetes. And they also mentioned that 90% of the diet came from white rice. Now, China has the second highest number of Tesla supercharging stations in the world after the US today. Now they brag in China that 12% of the population are diabetic, frankly diabetic, and half the people are either diabetic or pre-diabetic. US, same data. India, whatever. All right, I'm going to stop, but I do want to read this story one more time. I read it for you on Friday night, and you may have been tired and sleepy, but please bear with me, and then I'll be off stage. How do you tell the good guys from the bad guys? How can you tell? Remember my grandchildren, you saw them here last night. They're much older, 13, 10, and 8, but we only had 2 at that time. On vacation with my 2 grandsons, aged 3 and 6, we came across a crime scene with 2 police cars, 4 officers, and 1 bad guy. The boy's first question to me was, "What'd they do, Grandpa?" I told them I didn't know what the bad guy did. Next they asked, "How can you tell he's a bad guy, Grandpa?" I answered, "Because he's in handcuffs." They continued, "He doesn't look like a bad guy. His face looks nice. His clothes look clean." I explained to them that you can only tell who the bad guys are after they are caught. But before the discovery of their wrongdoings, they look just like good guys. And most of them even believe themselves to be good guys. Finally, my grandsons wanted to know if the bad guy was going to hurt them. But I assured the boys, the bad guy won't be able to hurt anyone if the authorities do their job. Are the authorities doing their job? You decide. Thank you very much. Okay. Well, we're going to take a break now.